Hello, my name is Alex Tate. I'm an analyst and I follow what happens in the field of skin-related diseases, psoriasis, atopic dermatitis, eczema, and so on. I'm currently focusing on the melanoma space, and I just wanted to call on your expert opinion with regards to the treatment paradigm in the BRAF population. At ASCO, I spoke to some US physicians who said that they start with immunotherapy because if you treat with a targeted therapy first, patients who progress have depleted T cells and may not respond as well to immunotherapy. But on the other hand, I went to an immunotherapy session where the presenters indicate that in patients treated with immunotherapy first, BRAF toxicity can be exacerbated. So this is a bit contradictory, and I was just wondering what your personal view and experience is in everyday clinical practice. As far as targeted therapies are concerned, how do you decide which patients to put on which drug? And when do you prescribe Tafinlar over Zelboraf or vice versa? I've seen that a few days ago the combination of Tafinlar and Mechanis was approved in the EU, which is exciting news. The data presented at ASCO is very positive in terms of response rates and PFs, and also the side effect profile look a lot better than the monotherapies. What would you say are the key benefits of the combo for patients? And what are the plus points most highlighted to the physicians community? Has the company started to talk about the combo? And how quickly can patients be expected to have access to the combo in the UK? And do you think that the new combo may become the new SOC? Do you think that NICE is likely to recommend the combo, or do you think there may be some issues with regards to reimbursement? And what will the NICE decision be based on, as there are already 2 monotherapies available for BRAF mutants? And in your opinion, what's the maximum price premium that the combo can command versus the monotherapies? How much more likely is it to be acceptable in percentage terms, roughly? And will the combination be expected to set up a patient access scheme that makes the combo available with a discount? Is the size of the discount likely to be identical to the one already in place for Tafinlar, or do you think it'll be higher? Great. Thank you very much for your help. Hello, my name is Alex Tate. I'm an analyst and I follow what happens in the field of skin-related diseases, psoriasis, atopic dermatitis, eczema, and I'm currently focusing on the melanoma space. And I wanted to call on your expert opinion with regards to the treatment paradigm in the BRAF population. At ASCO, I spoke to some US physicians who said that they start with immunotherapy because if you treat with targeted therapy first, patients who progress have depleted T cells and might not respond as well to immunotherapy. But on the other hand, I went to an immunotherapy session where the presenters indicate that in patients treated with immunotherapy first, BRAF toxicity can be exacerbated. So this is a bit contradictory. What's your personal view and experience in everyday clinical practice? And as far as targeted therapies are concerned, how do you decide which patients to put on which drug? When do you prescribe Tafinlar over Zelboraf or vice versa? Do you feel that the company provides enough guidance on how to deal with and manage pyrexia caused by Tafinlar? So does the company offer any specific support to help patients manage pyrexia? And what about Roche? Does the company help physicians on how to tackle the side effects? Which key safety concerns are physicians and nurses told to look out for with Tafinlar? And does the company talk mainly about pyrexia, or is hypertension also mentioned, or anything else? And what about Zelboraf? I mean, what are the main side effects that physicians and nurses are told to check for by the company? Do they mention photosensitivity? There was a session at ASCO where a presenter indicated that there are more brain relapses with Zelboraf than with Tafinlar. Is that something that's ever mentioned in conversations with the reps? And what about photosensitivity? Is that something that's presented as a plus for Tafinlar versus Zelboraf? So what are the key benefits of Tafinlar highlighted by the company with regards to efficacy? And what about Zelboraf? So I've been talking to some physicians in the US who say that the company is very proactive with regards to Tafinlar and very helpful to HCPs. Is that the same in the UK? Have you seen the reps since Tafinlar has moved under the umbrella of Novartis? And does the company communicate regularly? Okay, and how do they use emails, face-to-face visits, phone, etc.? And is any type of material provided to help physicians or nurses? Scientific papers, informative brochures, leaflets? In the US, physicians mention that there are some educational presentations and lunches at hospitals and cancer centres and talk about the benefits of the drug, dosing, treatment duration, adherence, how to deal with any side effects. Does the company do anything similar in the UK? Okay. And what about Roche? What do they do in terms of educational activities? Is the company present and helpful enough to HCPs? Great. Thank you very much for your help. Oh, hello, my name's Alex Tate. I'm an analyst. I read a paper you co-authored which was published in Nature around 3 weeks ago. The title is Targeting B-cell receptor signaling with ibrutinib in DLBCL, diffuse large B-cell lymphoma. Yes, I'd just like to clarify a couple of points, if that was all right. Are patients routinely screened for the above mutations in clinical practice? And in a real-life setting, how do we know roughly what percentage of ABC patients are BCR dependent? And out of those, what percentage have a BCR mutation or a double mutation of BCR/MYD88? And how do you screen for these mutations in your analysis? And how are your findings based on this small phase 1-2 trial impacting larger studies such as Phoenix? For example, further to the findings in this paper, is the Phoenix trial now screening for the two subsets of patients with BCR or BCR plus MYD88 mutations? Okay. And is the screening done via the same method you use in your analysis, or is there a companion diagnostic in place? And have any trial amendments been made to manage the two subsets of patients mentioned above? What has been changed? Okay. And do you think that going forward that ibrutinib will be restricted to BCR dependent patients, or will the drug have a chance to succeed or be approved in the more general non-GCB population? Great. Thank you very much for your help. Oh, hello, my name's Alex Ted. I'm an analyst and I follow what happens in the field of NHL, CLL, and I'm now looking at R/R-CLL. The approval of ibrutinib monotherapy and idelalisib and rituximab has changed the SOC for patients with R and R/CLL. However, novel approaches are needed to prolong disease control. There's a multitude of new potential combinations under investigation. For example, I understand that the data for the Helios trial with ibrutinib and BR versus BR is very impressive. However, some physicians are not convinced that ibrutinib and BR are significantly more effective than ibrutinib alone. I just wondered what your opinion was. I know this is very early stage, but which other combination? I'm looking at Medi 551 and B versus BR and ABT 199 plus R and ublituximab plus TGR 1202, etc. Which of those other combinations would you say looks the most promising in the R/R-CLL? I understand that there are also even some monotherapies under development in R/R-CLL. For example, duvelisib shows some promises in that patient population. The interim data for the phase 1 indicates that the single agent produces good response rates with very tolerable and manageable side effects. Do you think that duvelisib monotherapy has the potential to offer an additional option for patients with R/R-CLL? And I understand that there is a phase 3 underway with duvelisib versus ofatumumab in R/R-CLL. At ASCO, some investigators said that recruitment was slower than anticipated and would be likely to go on until mid-2016 or so, and others believe that the enrolment would complete by the end of the year. Do you have any view on that? How would you say things are going? I believe the target number for GEO is 300. Do you know how many patients have been recruited so far? I was talking to an investigator at ASCO who felt that we probably wouldn't see any data before 2017 at the earliest. What's your opinion? When do you think some data might be available? Okay, an interim analysis, is that expected? Do you know when that's scheduled to happen? And what about the final analysis? Great. Thank you very much for your help. Hello, my name's Alex Tate. I'm an analyst and I follow what happens in the field of biologics and their current and future role in the treatment of inflammatory diseases. And one of the MOAs that I'm looking at is the anti-IL-13, which is explored in a number of TAs. And one of the compounds I've come across is the QAX576, which seem to have been investigated in a variety of conditions: IPF, asthma, eosinophilic esophagitis, and also Crohn's disease. So the latest study in Crohn's disease seems to have been completed back in 2013, and the compound doesn't appear to have been pursued in this indication. And I was wondering, do you know why? And is that due to lack of efficacy, or is it company priorities? And I know that in asthma, the company is combining the QAX576 with the VAK694, which is an anti-IL-4. The combined compound is called QBX58. And bispecifics seem to work quite well in a number of conditions. Do you think a combination could work in Crohn's or UC? And are there any plans to take the QBX258 in these two disease areas? Okay. Thank you very much for your help. Oh, hello there. My name's Alex Tate. I'm an analyst. I'm currently looking in the treatment of severe asthma. There are a number of new approaches under investigation with various classes of biologics: anti-IL-5s, anti-IL-13s, the bispecifics, the new generation anti-IgEs. I just wanted to find out, how do you see the severe asthma treatment paradigm evolve with these new biologics coming to the market? I attended the last couple of conferences where some key data came out on the anti-IL-5s, mepolizumab, benralizumab, reslizumab, and one of the biologics which physicians seem to be pretty enthusiastic about is dupilumab. The interim analysis of the phase 2b was presented at the ATS, but the main focus was on FEV1 and exacerbations, and there was no mention of the less crucial data. Did dupilumab show a positive impact on the ACQ-5 score, like it did in the phase 2A? And was that significant? And was it sustained throughout the study? And what was the change then from the baseline? And do you know when one could expect to see the data on the ACQ-5 to be presented or published? From what I understand, all comers are allowed in the study independently of eosinophil levels. Is that right? Are patients then stratified by eosinophil levels? Okay, and what's the threshold or cutoff used in the stratification? 300? And what are the requirements in terms of exacerbation history in the 12 months prior to the study? So are patients on OCS excluded from the study? So I guess the OCS sparing effect will probably be looked at in a separate study. Do you know when that might be expected to start? Okay, great. Thank you very much for your help.